Hello. Thank you very much for the opportunity to talk to you today at the WHO 2021 meeting. My name is Martin Hutchings. I'm a senior consultant at the Department of Hematology in the Phase 1 unit at Rigshospitalet in Copenhagen, Denmark. And I've been asked to give you an update from the recent ASH meeting in December 2020 on aggressive non-Hodgkin lymphoma with a focus on diffuse large B-cell lymphoma, which is a particular interest of mine. I've selected 5 different abstracts, one of which was presented as a poster and the 4 others presented in oral sessions. This is a very subjective selection. I could have chosen many others, and you might say, where is tafasitamab, where is selinexor? And I completely agree that we could have chosen other things to talk about today. These are my disclosures. I also have a temperature of 39 degrees Celsius after my second Pfizer-BioNTech jab earlier today, but that does not really qualify as a conflict of interest, I believe. So the first abstract was presented by Julien Depot. It's called Interim Results of loncastuximab tesirine combined with ibrutinib with diffuse large B-cell lymphoma or mantle cell lymphoma. This study is referred to as LOTIS-3. So Lonca-T is an antibody-drug conjugate with an anti-CD19 antibody, which is conjugated to pyrrolobenzodiazepine and dimetoxine via a cleavable linker, much like the brentuximab vedotin and polatuzumab vedotin linker. And as you all know, ibrutinib is an inhibitor of Bruton's tyrosine kinase. So LOTIS-3 is an ongoing single-arm phase 1/2 study which evaluates Lonca-T and ibrutinib in patients with relapsed refractory DLBCL and also in patients with relapsed and refractory mantle cell lymphoma. And initial results from the phase 1 part of this study were presented also by Julien at the EHA meeting earlier in 2020. And at that presentation, the recommended phase 2 dose, or the maximum tolerated dose of the combination with 60 micrograms per kilo of Lonca and 560 milligrams per day of ibrutinib was determined. And this poster at ASH gave basically an update of the efficacy and safety from the phase 1 portion of this study. This is an outline of the study design. So the phase 1 and the phase 2 parts are slightly different. We'll focus here on the phase 1 part, where patients had 2 cycles of Lonca combined with ibrutinib daily basis, then an assessment. And in cases of a complete response, they would continue with ibrutinib only. In cases of partial response or stable disease, continue with another 2 cycles of Lonca and continue with ibrutinib daily until progression. So 37 patients, of whom the vast majority had diffuse large B-cell lymphoma, 30 of them were included in the study and included in this update. And interestingly, out of the diffuse large B-cell lymphoma patients, 80% had non-GCB subtype, which is logical since we expect to see the most efficacy with ibrutinib in this patient group. The patients were not so heavily pretreated. The median prior lines of therapy were 2, ranging from 1 to 6, and only 22% were refractory to first-line therapy, which is not so high when you compare with similar studies for relapsed refractory disease, and 49% refractory to the most recent treatment line. Only 11%, that's 3 patients, had a prior stem cell transplant, 2 of those autologous, and 1 allogeneic stem cell transplant. So these are the results from the given at the ASH presentation. On the left, you see the response rates in the different subcategories. As you would expect, not so many responding patients with GCB, diffuse large B-cell lymphoma, but good response rates of 67% in non-GCB DLBCL and even higher in mantle cell lymphoma, as you would expect from an ibrutinib-containing combination. So 29% of the responses in DLBCL non-GCB were complete responses and 37.5% complete responses and the remaining partial responses. Looking at the toxicity profile, the most common side effects seen were thrombocytopenia, seen in 30% of patients, and then anemia, fatigue, and diarrhea, all seen in 22% of patients, quite consistent with what you would expect to see from ibrutinib, at least the latter 3. And the interesting update from this presentation really was the durability of the responses. You see on the right the swimmer plot. that the majority of responding patients, both with mantle cell lymphoma and with non-GCB diffuse large B-cell lymphoma, really quite durable, with the majority of patients still being on active treatment at the time of the data cut for this analysis. The next abstract I've chosen was presented by Christopher Milani from the NIH. And this is the presentation of the phase 1b/2 VIPOR study. VIPOR is the acronym for the combination of 5 different drugs, which is venetoclax, ibrutinib, prednisone, obinutuzumab, and lenalidomide, which is given in relapsed refractory B-cell lymphomas of different kinds. Now, the combination of obinutuzumab, prednisone, ibrutinib, and lenalidomide has been tested in several studies, and so the doses of the different drugs have been determined. Now, venetoclax is the add-on. Venetoclax was added in a dose escalation fashion. That was the phase 1b part of the study. So this is a layout of the study, a fixed duration schedule, 6 cycles of each 3 weeks. And you can see that both ibrutinib and lenalidomide given for 2 out of the 3 weeks, so 14 days out of 21. Venetoclax also given with a week's pause in between, obinutuzumab on day 1 of every cycle, and prednisolone for 7 days of each cycle. So for this analysis, 58 patients were included, and we'll focus on the 35 patients who had aggressive B-cell non-Hodgkin lymphoma. These included 20 patients with diffuse large B-cell lymphoma and 15 patients with high-risk disease, either double or triple hit B-cell lymphoma, so high-grade B-cell lymphomas. Now, 40% of all these 35 patients had non-GCB, DLBCL, 37 of them transformed disease, so transformed mostly from follicular lymphoma, and as many as 63% with an IPI score of 3 or more. Now, these patients were more heavily pretreated than in the previous abstract, so the median prior lines of therapy was 3, ranging from 1 to 9. And interestingly, 57% of the aggressive NHL subcohort were refractory to the most recent line of therapy. Now, this is a slightly busy chart, but it basically goes to show that even though a combination is chemo-free, it doesn't mean that it's side effect free. So this slide presents all the adverse events of grade 3 or higher. On the left, the hematological adverse events counted as per cycle. So in total, these 58 patients were treated with 260 cycles of the combination. And you can see that the most common hematological side effects were thrombocytopenia and neutropenia, but this led only to very few cases, in fact, only 3 cases of febrile neutropenia, all of which were managed well. And you can see that GCSF was used in 90% of all cycles, and it was actually made mandatory during the study for patients to receive GCSF. 800 milligram of venetoclax was chosen as the recommended dose. So the full dose of venetoclax essentially was considered safe in combination with the 4 other drugs. On the right, you see the non-hematological adverse events counted here per patient. So out of the 58 patients, the most common grade 3 to 4 adverse events were hyperkalemia, elevated liver enzymes, diarrhea, and atrial fibrillation, all quite consistent with the individual components of this combination. Now, this is the activity seen across all the different histological subtypes. You can see that many of the responding patients had indolent lymphomas, but there were also frequent and deep responses observed in the more aggressive histologies that we're focusing on here. And here you see the overall responses and complete responses in patients with the aggressive B-cell lymphomas in DLBCL of non-GCB and GCB subtype. As you would expect, again, in an ibrutinib-containing combination, most activity is seen among those patients with non-GCB, with as high a complete response rate as 57%, and on top of that, another 7% reaching partial response, adding up to a total of 64% overall response. And as you can see, particularly lower rates of complete responses among those with GCB subtype DLBCL. On the right, you see the progression-free survival curves. Actually, the follow-up is quite long in this study, and you can see that among those patients with non-GCB DLBCL, they are represented by the blue curve. You have still at 1 year's follow-up a progression-free survival rate of 44%, which in this context of heavily pretreated patients should be considered quite good. So the next abstract I've selected was presented by Sattva Neelapu, and I know that he has been talking to you earlier today at this meeting, so I will only mention his excellent presentation very briefly, and that will be the only CAR-T abstract that I will include in this talk. Now, Sattva presented the results from the ZUMA-12 study, and ZUMA-12 is a study of axi-cel in the first-line treatment of high-grade B-cell lymphoma and high-risk diffuse large B-cell lymphoma. So these are either high-grade BCL or diffuse large B-cell lymphoma with an IPI score of 3 or higher, much like the previous abstract. Now, unlike many of the CAR-T studies that we've seen, these are actually patients treated in first line, but not upfront. So patients with high-risk features, like I described, were given 2 cycles of anti-CD20 and anthracycline-containing regimens, mostly R-CHOP, of course, as you would expect. And then a PET-CT scan was performed after 2 cycles of treatment, and patients who could be considered non-responsive to treatment according to the Deauville score, 4 or 5, would be eligible for enrollment into this study of axi-cel. 37 patients were enrolled and 32 patients actually received the T-cell product. On the right side, you see the responses. 85% overall responses, including 74% of patients with a complete response and 11% with a partial response, and the remaining 15% all had stabilization of disease. So no patients had progressive disease as the best response. And remember, these are high-risk patients with a PET, with a non-response on PET at interim, and we all know how tricky a situation these patients are in, how difficult they are to treat, and how difficult they are to get into complete response. You can only think about what the PET response adapted studies that have otherwise failed would have looked like if escalation of therapy had been performed with CAR-T rather than the intensive chemotherapy regimens that have been otherwise used in order to help these patients with poor response to initial treatment. So this is, for someone like me, particularly interested in PET scans and its use in lymphomas, it's a tremendously interesting abstract. So the next abstract I presented is a little bit immodestly, it was presented by myself. It was the ongoing phase 1/2 study of the bispecific CD3/CD20 antibody epcoritamab in different subtypes of relapsed refractory B-cell non-Hodgkin lymphoma. Now, epcoritamab, it's an ongoing study. The phase 1 part of the study has been completed, and dose expansion, called phase 2 in this case, is ongoing. So this is just a brief outline of the study. Patients started at very low doses, as you would expect in phase 1 immunotherapy studies, and without reaching any dose-limiting toxicity, the dose of 48 milligrams was chosen as the recommended phase 2 dose after the full dose expansion, the full dose escalation. There were a few patients treated at 60 milligrams, but 48 milligrams was chosen not based on toxicity, but based on PK profiling. It didn't seem to add to the T-cell activation or to the occupancy of receptors to increase the dose further than 48 milligrams. In this study, patients were relapsed refractory with B-cell non-Hodgkin lymphoma. They all had to be treated with prior lines of treatment with anti-CD20, monoclonal antibodies, and chemotherapy, and they had to have reasonable ECOG performance status of 0 to 2, the vast majority being 0 to 1 in this case. So this is an outline of the characteristics of the patients. And as you can see, out of the 68 patients included in the dose escalation part of this study, 46 had diffuse large B-cell lymphoma. And like I said, these are the ones that we focus on in this presentation. They were quite heavily pretreated. You can see that the prior lines of therapy, the median was 3 in DLBCL, ranging from 1 to 6. All had received anthracyclines, all had received alkylators, all had received rituximab or obinutuzumab. And if you go a little further down, you can see that they were really quite sick. 91% had been refractory to the most recent treatment line, and 91% had been refractory to CD20 containing treatment lines. This is a look at the safety from the phase 1 part of the study. You can see that the most common side effects are cytokine release syndrome and related symptoms, which really can be encompassed into the CRS complex. So the majority, just a small majority of patients experienced CRS, but you can see from the color grading that only grades 1 and 2 CRS were observed. So there were no cases of grade 3 or 4 cytokine release syndrome. So other side effects, pyrexia, which kind of goes with cytokine release syndrome, and also injection site reactions. And this leads me to mention that this is a subcutaneously administered antibody, unlike the other 4 or 5 bispecifics that are under development in using CD3 and CD20 as targets for treatment of diffuse B-cell non-Hodgkin lymphoma. You can also see that there are some constitutional symptoms met almost invariably in studies of relapsed refractory DLBCL. Interestingly, there were no cases of febrile neutropenia, fortunately no treatment-related deaths, and neurological side effects, which are otherwise seen relatively commonly in T-cell engaging therapies, and particularly CAR-T, very uncommon, only observed in 4 patients in this study, all of them transient and quite manageable, 2 of grade 1 and 2 of grade 3. Now, apart from being mild to moderate, grades 1 and 2, CRS events were almost exclusively reserved to cycle 1, so that is the first 4 weeks of treatment, which of course also makes it quite predictable and manageable in an outpatient setting. Now, this is a rough overview of the responses seen in different histological subtypes, and I think we should focus on diffuse large B-cell lymphoma patients over here, 46% being the majority of patients included in the study. Like I showed you that some patients were treated at very low doses, but at doses considered clinically meaningful, where we saw some meaningful responses, they were observed in doses of 12 milligrams and higher. You can see that if you include all 23 patients evaluable for response treated at doses of 12 milligrams and above, the response rate in diffuse large B-cell lymphoma overall was 68%, with 46% being complete responses. And at the recommended phase 2 dose, even though the numbers are small, 11 out of 12 patients had been treated at, were evaluable for response, and 91% were responders, including 55% with complete responses. So I think fair to say that these are, despite the small numbers, we still need to have this confirmed in larger patient cohorts, but on par with what we've seen with CAR-Ts. Now, looking at the responses and focusing only on DLBCL, you can see in the swimmer plot in the bottom left of this slide that the vast majority of responding patients have ongoing responses at the time of the most recent data cut. So even though follow-up is quite short, the median is under 6 months, you will see that the vast majority of patients still are on treatment, and most of those who are not on treatment because they have gone on to a subsequent stem cell transplant, 1 case of allogeneic and 2 cases of, 2 cases of allogeneic and 1 case of autologous transplant. You can also see from the waterfall chart that all patients treated at the recommended phase 2 dose or above, so 48 or 60 milligrams, had tumor reductions. So those patients on the left side of the waterfall chart here who did not have tumor reductions or response, they were all treated at 12 or 24 milligrams, which is a quarter or 50% of the recommended phase 2 dose. On the right, you just see a recap, 68% overall responses in patients treated at 12 to 60 milligrams, 91% overall response in patients treated at the recommended phase 2 dose of 48 milligrams or above. And the last abstract I've selected was also given by myself, I said, and this is an update from the ongoing phase 1 study of glofitamab in relapsed refractory B-cell non-Hodgkin lymphoma. So this abstract really is not so much an update of previously presented data, but the first presentation of a step-up dosing regimen which has been introduced during the study, during this ongoing phase 1 study. So this is basically a recap of the most recent update of the general data from the study, which was given by Michael Dickinson at the EHA meeting in June of 2020. And as you can see at this point, with roughly 150 patients treated on the study, very frequent and deep responses were observed both in aggressive B-cell non-Hodgkin lymphoma and in indolent disease. And looking on the right at the durability of responses, you can see that in patients with CR, the vast majority kept their CR at least through the follow-up period so far observed. And this goes for both indolent and aggressive histologies. On the bottom right, you see an overview of the duration of response, and I'd like to direct your attention to the blue box, which are the patients with aggressive B-cell non-Hodgkin lymphoma. The median follow-up for this presentation given in June was 10.2 months. You can see that the median duration of complete response has not been met at this point, and out of 24 patients with ongoing complete responses, 10 of those had ongoing complete responses for more than 12 months. And I think it's fair for us to quite eagerly await further updates from this study. But this was not the scope of my talk at ASH. It was really to give a presentation of a new way to give glofitamab. So far, glofitamab had been given at fixed doses, so without step-up dosing, which is otherwise used with the other competing CD3, CD20 bispecifics, which are under development. And there's a reason for this. So if you look on the left, you see the data presented by Michael at the EHA meeting in June. And what you see is that going towards the doses of 16 and 25 milligrams, which is where the dose escalation stopped, you see quite high rates of cytokine release syndrome, 78% at 16 milligrams and 100%. So all patients treated at 25 milligrams experienced cytokine release syndrome. And you can see that the majority had either grade 2, 3, or 4 CRS. So this was considered unacceptably high frequencies and also severities of CRS. So from then on, the study was changed and we introduced step-up dosing. So instead of starting at the full dose of glofitamab, step-up was introduced, starting at 2.5 milligrams the week after 10 milligrams, and then the week after the final dose, which began at 16 milligrams and was escalated quite quickly up to 30 milligrams. All patients throughout the study have been treated with a single dose of obinutuzumab 7 days prior to the first dose of glofitamab. This is a mitigation strategy to avoid serious CRS. It worked at the low doses, but as you can see, it wasn't enough when we reached the higher and clinically meaningful doses. So this slide shows you a comparison of the efficacy of glofitamab on the left with the fixed dosing, and on the right in the smaller group of patients, 52 all in all, who were included in the step-up dosing cohorts. And if you look only at aggressive non-Hodgkin lymphoma, that's here in the middle, 49% overall responses, including 34% with complete responses as presented by Michael at the EHA. In the more recent presentation, 60.7% overall responses, including 53.6% complete responses. And interestingly, actually, this is probably underestimated, since some patients, both with aggressive non-Hodgkin lymphoma and particularly with indolent non-Hodgkin lymphoma. I believe 2 patients with aggressive and 6 patients with indolent disease did not have, had not reached their first response assessment at the time of the data cut for this presentation, and they are all counted as non-responders in this calculation. So we're still looking at the efficacy, and now we are looking only at patients treated with a step-up dosing regimen. On the left, you see the waterfall chart. You can see that the vast majority of patients have meaningful tumor reductions, and like I said, in 61%, living up to the criteria of either a partial or complete response. And just like in epcoritamab, complete response is seen in more than 50% of all patients with heavily pretreated diffuse large B-cell lymphoma. Now, since this study was changed from fixed dosing to step-up dosing, the more recent patients have been given step-up dosing. So of course the follow-up is short. So on the right, you just see a very preliminary assessment of the durability of responses, but you will see that the majority of patients with responses still have ongoing responses. And unlike epcoritamab, which is given until progression, patients on glofitamab treatment are treated for a maximum of 6 months and then followed with the option of retreatment if responding patients later relapse. Now, looking at the safety, which was really the main scope of the step-up dosing, it was to control safety. On the left side of this slide, you see a panel that I already presented. That was the background for the change to step-up dosing. On the right, you see the similar picture for patients treated with step-up dosing, either 2.5, 10, 16 or 2.5, 10, 30 milligrams of glofitamab. And you will appreciate that even though the overall rates of CRS are more or less the same as with fixed dosing, we see much fewer cases of severe CRS, fewer cases of grade 2, and particularly fewer cases of grade 3 and 4 CRS. In fact, grade 3 and 4 CRS has only been observed in 2 patients, so 2 out of 52 patients since the introduction of step-up dosing, without losing efficacy. In fact, I think it's fair to say that efficacy is at least as good and probably even better than with fixed dosing. Now, these are just happy pictures. They are both patients treated at my institution with glofitamab. We have similar pictures from patients treated with epcoritamab. On the left is a lady with Richter transformed CLL. She had 8 prior lines of treatment for her CLL. And 8 prior lines of treatment, 5 of them given for CLL and 3 of them given for the transformation of disease. And she had been refractory to all attempts at treating her Richter transformation. And she was included into this study of glofitamab. And as you can see, even though she had very extensive disease at baseline, she had a complete response after just 2 cycles of treatment. And much the same on the right, a 67-year-old chap with a non-GCB DLBCL. He had only had 3 prior lines of treatment, but he'd been completely refractory to both of his salvage attempts. And also he had a very deep response despite extensive disease at baseline. He was not quite in a CR, and you can see there was a little bit of a PET uptake in his abdomen, but certainly a very clinically meaningful response. So with this, I would like to thank you for your attention and pay my acknowledgements to the most important people in this context. They are the patients and their families, of course, the study nurses and coordinators, also the colleagues who have been so kind as to provide slides for this presentation, and to my co-investigators and the study teams behind epcoritamab and glofitamab. Thank you very much.